I have the privilege of introducing our plenary speaker tonight, Richard Frank. Richard probably doesn't know how much I admire and appreciate him, but he's about to learn because you guys are in for a treat. He has a new day job. Richard is the Assistant Secretary for Planning and Evaluation for Health and Human Services. I mean, he's right up there in Sylvia Burwell's grill every day. He had to be appointed. He works for President Obama. He is in the business right now of making real-world decisions, real-world advice about health and disability and human services and data and economic policy has implications for all of us. That's what he does for a living. He's on leave right now from his long-standing position at Harvard Medical School, where he's the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard. He's been there for over 15 years, I think, doing that job, building, developing, and leading a wonderful program of economists and policy researchers and policy advisors and policymakers. Before Richard started working in what you might call the real world of high-risk actual implications that affect you and me every day kind of life, he was, and still is, a distinguished scholar. Richard is the kind of scholar who's written about 250 papers. He's gotten 40 grants. He's written about 70 book chapters. He's the kind of scholar that you just wish that this was the kind of portfolio that you had to defend when it came time for promotion and tenure. He's the real deal. He also is a consultant. He's been a consultant for the VA. He's been a consultant for both APAs, for the states of Massachusetts, Ohio, New York, the Carter Center, and the list goes on. Fairly high profile, fairly useful guy. People kind of think the advice they get from him and the perspective they hear from him is good. He's been in the Institute of Medicine for about 17 years, and in fact, let's see, I've heard Richard talk maybe 10, 12 times in my life. There's not a single time that I have heard Richard speak that I didn't learn something that I didn't know. And the few times when I differed in my opinion of his conclusions, it was because I wasn't thinking of something. Richard is not an ordinary genius. He's a brilliant man. He's not brilliant in the ordinary sense. He's not the kind of brilliant where if you just read more or you just study harder, you can be like that too. Richard is brilliant. In fact, the last time I heard him talk was at an Institute of Medicine committee. We're sitting around trying to figure out what we're there for. Richard comes in to sort of give us a charge, and you don't know this, Richard. He left, he had to go to work, and we kind of went, oh, so that's why we're here. That's what we're supposed to be doing. Now I get it. Now we know how to do this. It was a very beautiful moment, and it's one of many that I've had listening to Richard talk. So here's what I think you're in store for. Richard is brilliant. He's a really smart guy. Okay, that's good. That's nice. I like that. Okay. He's really blunt. He will speak the truth, and he has no fear about doing that. I really like that. This is going up on my approval meter here. He's clear, and he's kind. And he is usually right. And so I'm really glad, and I sleep a little bit better at night knowing that policy advice about health and disability and so forth is coming from this guy. If the rest of our leadership in this nation were as accomplished and were as stable and balanced as Richard is, I think we would probably be living in a much better country now. Richard, this water glass sitting here is for you. It's clean and you can drink out of it. I wish y'all would join me in welcoming Richard Frank to be our plenary speaker.
Thanks. I've learned one thing since being confirmed by the Senate, which is that when you have a budget that supports research, suddenly you become taller, wittier, better looking to academic department chairs. But thanks, Frank. This is it'll work. Anyway, I am very pleased to be here, and I apologize for actually coming in a bit late. This, believe it or not, is the friendly, relaxing part of my day. And, well, friendly you can probably believe. Relaxing you wouldn't think. But literally just before I got in the car to get here, I got an email from the Chief of Staff asking me a question about some research on Ebola. Okay? Now, when you start asking a health economist about things around Ebola, you know things are desperate. But it actually was a question that presumably it was about sort of regulating travel and things like that and what the consequences are. But anyhow, it's that was the kind of day it was. Anyway, I think I left. Oh, so what I wanted to do here this evening is really touch on three general areas. One, I wanted to spend a little bit of time with you sort of placing the ideas of integration of behavioral health and general medical care into the context of the Affordable Care Act and the opportunities that it creates. And there's really two kinds of opportunities that are created by the Affordable Care Act. The first is that we expand coverage, and we expand particularly coverage for behavioral health care, which brings new resources into the picture. The second thing is that we create new ways of paying providers and new organizational arrangements that have the potential possibly to advance ideas around integration, early interventions, and the like. So I want to first quickly walk you through some of the opportunities that come out of the Affordable Care Act and also some of the economic philosophy that's embedded within it. Then I was going to talk a little bit about what has been found to work and why on both bringing behavioral health care into general medical care, which is a lot of what Frank's work. And by the way, when I've disagreed with Frank, it turns out that I've usually been wrong. And so he didn't quite tell the stories right. But what I want to do is sort of take that set of evidence, which is very robust and very deep. And so I won't talk a lot about it, but I just want to sort of note the bottom lines. And then I want to turn to something that's a little bit newer and a little bit trickier, which is what happens when you try to bring general medical care to specialty behavioral health. And I'm going to show you some results from an evaluation that we've been doing on the primary care behavioral health integration demonstration program that has been run by SAMHSA since about 2010. And, you know, we're $120 million plus into this, and so it's probably a good thing to, you know, every $100 million or not, ask yourself whether you're spending your money wisely. And so we're going to do that. And then what I wanted to talk a little bit about is what have we learned about what gets in the way, and what do we want to do to actually promote both of these kinds of models going forward. Okay? And then hopefully we'll have time for questions. So again, let me just, again, touch on the first two things. So the expanded resources, the expanded coverage opportunities really come in two pieces. One, parity, mental health and behavioral health parity on one hand, and then the expansion of coverage under the Affordable Care Act, and the fact that the Affordable Care Act actually brings those two things together. A coverage expansion and an insurance mandate with a requirement to treat behavioral health on the same footing as you treat general medical care. The second part is the payment systems and the institutional change, and I want to talk a little bit about that and the philosophy behind it, because in fact that's at this point the most important unfinished piece of business in the Affordable Care Act. You know, we now have an exchange, a set of exchanges that are working. Medicaid expansion is cracking right along. Tomorrow there's going to be a release of some new numbers. You heard last month some numbers on Medicaid where we've added 8 million new people over the last year. We're going north from that tomorrow. And so, you know, we've knocked somewhere between 10 and 12 million people out of the ranks of the uninsured this year. So, so that's good news. And the really hard work, in addition to making sure that we sustain that, is starting to move the delivery system reform away from volume and towards value. And so that's really, so I'm going to give you a little bit of economics 101 of delivery system reform. So on we go. So now here's some people to clap about, not me. So you've got Paul Wellstone there on the upper left, Pete Domenici on the right, and then Teddy and Patrick Kennedy below, standing on either side of President Bush, Pete Domenici, and then Ramstad, who was the co-sponsor in the House. And so really what we saw in 2008 was that private health insurance, large employers were required to cover behavioral health services on par with general medical services. And that is extraordinarily important, and it was actually driven by evidence. For years, there was a debate about how much it would cost, and then the Federal Employees Health Benefit Program actually tried it, evaluated it carefully, and found that it didn't drive up cost much. It covered people, it protected people from the biggest risks, and it didn't cost a lot of extra money. And so, based on that, there was a willingness by the Congress and by the Congressional Budget Office in their scoring to sort of enact legislation that had really been in process for a long time. I was telling my son in 2008 that I was, really passionate and excited about this development because I'd been working on it a long time. So he goes, when did you start working on it, Dad? And I said, well, I wrote my first paper on this with Steve Sharfstein and Howard Goldman. We wrote it in '79. It was published in '80 or '81. He looked at me and goes, work slow, huh? So anyway, now the limit on parities was that it didn't force people to offer mental health coverage or behavioral health coverage of any type. It just said, if you do, you have to treat medical and behavioral health on par with one another. And it didn't cover small employers or the individual insurance market. So there were some fairly big holes. So along comes the Affordable Care Act, and this is actually one of my favorite pictures. just because if you look at the lower right-hand side, we'll play a party game here. Can anybody name the man on the lower right-hand side who's sitting? Yeah, it's John Dingell. And what's so important about that is John Dingell's father introduced one of the first national health insurance legislation in the House, basically a generation ago. And the fact that he was sitting there on the day of the signing to sort of close the loop on his father's work was really rather remarkable. Anyway, so what the Affordable Care Act did is it took parity and it married it to a mandate. The essential health benefits requires that mental health and substance use disorder services be covered in all qualified health plans, both inside and outside the marketplaces. That means everything. And then when you marry that with parity, it says not only do you have to cover it, but you have to cover it on par. And so that's, to quote our Vice President, a big deal. So here you go. A move towards universal coverage. The essential health benefits require mental health, and then you layer on parity, and it really completes the package. So here's the impact. Here are the estimated impacts. And I'll just draw you to the three numbers at the bottom of the slide, which is roughly 30 million people will have behavioral health coverage for the first time, and behavioral health coverage at parity for the first time. The second column has the number 30.4 million at the bottom. That is people whose coverage will be improved because of the Affordable Care Act and parity. And then in total, roughly 61 million people have had their insurance, their behavioral health benefits changed because of this policy. So that is, as I said, a big deal. Okay, that's the coverage story. That's where we are on that. So lots of new resources. This is Medicaid. This is private health insurance for a whole new set of people. And that means more money is going to be flooded. And it's particularly dramatic on the substance use side, because the coverage there was even more limited. Now, let's turn to delivery system reform, which is the new way of organizing care. And you've probably heard a lot of these names before: accountable care organizations, Medicaid, health homes, innovation centers with bundling, patient-centered medical homes, and so on. And each of those is an attempt to try to reorganize the way we deliver care. So let me tell you what the underlying sort of strategy is, which is the idea is to take more services and put them under budgets, and to delegate those budgets to clinical organizations that have the broad set of capabilities to meet the needs of a population. Okay? That's where we're headed. Now, we're not going to be there 100%, but what you see is even the incremental steps, bundling, health homes, primary care, patient-centered medical homes, all of them are steps in that direction, where we're putting more dollars under budget-like things and giving them to clinical organizations to manage. And going along with that are requirements that we measure performance and hopefully get some savings from the healthcare delivery system by reducing waste, by reducing duplication, and streamlining patient care. Now, that is sort of the high-level philosophy behind this. What's important to recall is that this high-level philosophy puts into place some very high-powered incentives, because Now you're paid, you gain by doing less, right? The business model here relies on two things. One, it relies on saving money if you meet a quality standard, okay? So that changes the business model. And we hope it changes it in a good way. But what it does is it puts a lot of pressure on our ability to measure performance, right? Because when you put high-powered financial incentives on people to spend less, very often they'll become more efficient and do a better job. But sometimes they'll try to cut corners, cherry pick patients and the like. And so the way you prevent that is by measuring quality, by measuring performance, by making sure that the most vulnerable get treated. And this is something we worry about. And so what's critically important is that we measure performance in ways that are consistent with the evidence-based models that work. And behavioral health is, in a sense, it's a mixed picture for behavioral health. On the one hand, the reason that all of you are here in some sense is because you deeply believe that when you integrate care, you do a better job and you do it more efficiently, right? And so, in a sense, what you can do, what you hope will happen is you'll take people, and I always think of people with diabetes and depression, right? Been shown to be really high cost. If you do collaborative care with those people, you actually save money, they do better, and that's sort of in a sense, the model for why we want to integrate. Now, that is only true if we make sure that there are incentives in place to hold people's feet to the fire to do that rather than to sort of end run the process. So you have to be always vigilant that when you place these new incentives and these new organizations in place, you're on the one hand creating the incentives for efficiency, but not for stinting, shirking, and cherry picking. So let me now turn to integration, because in fact you would think that these incentives would provide a pretty good path to doing integration, right? That an organization like an accountable care organization would say, gee, if I take those high-cost patients, diabetic patients with depression are really high cost, and I do a better job managing them, I will bring down the cost of treating those people, but I'm still going to be getting paid something related to my historical average. So there's opportunity there for me as an organization to benefit financially and to do good clinically. And so that's what you hope the motivation will be. So now I want to spend a little time talking about how we're starting to think about integration. And very often it's meant bringing mental health care into a primary care setting. And while I think that's true, that's not quite the philosophy, at least of this administration. This administration is committed to patient-centered care, and what that is interpreted as meaning in this area is meeting people where they are. Okay? So people with mental and addictive disorders are extraordinarily heterogeneous in their circumstances and in the circumstances of their illnesses. And what that means is that they're going to touch the healthcare system in a lot of different places and in a lot of different ways. So I think about people with schizophrenia. Most of them mostly touch the health system at a specialty behavioral health center. Whereas probably well over half people with depression touch it in a primary care setting. Well, you want the benefits of integration to hit on both sides. And so that means not forcing people into one setting or another, but rather bringing the benefits of that integration to them. particularly for people with severe and disabling conditions that under good circumstances have trouble negotiating complex environments. And the health system is one really complex environment. So, so we view the integration going two ways in a very basic way, and that's what we mean by meeting people where they are. And there's lots of evidence to support why we do that. People with severe and persistent mental illnesses often suffer from a variety of other chronic diseases. That's reflected in their higher rates of mortality. That is roughly a 4-time risk of mortality of early death. And this is partly due to the illnesses, but partly due to the circumstances that travel with the illnesses. Poverty, treatments that are toxic, and the like. But just to give you an idea, the average Medicaid recipient with schizophrenia, we spend about $18,000 on a year. Well, actually, 17,000, well, you know, almost $18,000 a year, compared to about $4,000 for the typical Medicaid enrollee. So what is notable about this is two things. One, it's a lot of money, but two, about a little over a third of it is for medical care that's unrelated to their direct mental disorder. It's not to treat their schizophrenia, it's to treat their hypertension, their congestive heart failure, and the like. And so they are at risk for those other chronic conditions. So the two big ways, the two big models out there are the collaborative care model, which, you know, I'm using as a big umbrella. It means more than what happens in Seattle. But those principles are at the core. And then the other side is how do we bring primary care to specialty behavioral health settings? And really the challenge here is figuring out what works, what we can measure, to put into that quality, that performance system that will then create incentives for people to scale these interventions and to bring them into these new organizations. And so that's what I want to spend most of the rest of the time on. So, you know, I first started reading Frank's work because I was interested in understanding the sort of work around collaborative care and primary care and depression. I think that's the first time we met. He, back in the day, I think it was called consultation and liaison psychiatry, if you were a specialty side, but that's where all this came together. What I think is so impressive is that literature is so deep and so robust. And not only is the clinical trials thing really impressive, but the demonstration side is equally impressive. And the reason is congressmen and people like me read a lot of these studies, and the first question you have to ask is, oh, it's going to do all these wonderful things. Will it do so in practice? Because the world is littered with boutiques that didn't work. And what's so impressive about this is whether you do this in the Rio Grande Valley of Texas, or you do it in Western Massachusetts, or you do it in New York City, you get almost equal success in all those places if you sort of are true to the model. And that's something that really starts to, when you compare it, when you put it alongside the clinical trials data, it's very powerful. So we have that on the bringing behavioral health to primary care side. We don't have that so much when we think about bringing medical care to behavioral health settings. The evidence is much more limited. There are some promising models. As I walked in here, I saw that big banner for the Cherokee Health System, which is kind of sort of, at least from a distance, it's one of the things that I've been so impressed by in reading the work that they've done. And so I was just thinking, boy, that's great that they're here. I'm bringing coals to Newcastle. But anyway, we've made $130 million at this point in investments in the demonstrations to learn about how to do that. I'm going to show you a little bit about what we've learned. So first, here's the meta-analysis that's now famous by Gilbody and colleagues, which is really, there are really significant and persistent clinical gains to doing collaborative care for depression and anxiety. And the two big elements, and there are more, but the two really powerful elements seem to be medication adherence and the credentials and supervision of the case managers. And I just want you to hold that in your mind because I'm going to come back to that a little bit in a few minutes. Okay. Now, this is because it is important, now that I've left academia and I'm in government, I have to retain the aura of being a nerd. And so this is some work that Sherry Gleed and I did, where what we did is we took all the clinical trials that we could find that had any information on resources, utilization, anything, and we turned them into cost-effectiveness data. Okay? And then what we did is we lined them up against the major criteria for what is a, quote, cost-effective intervention. And we used the British, who are the stingiest, which is the ones, the Ray over on the right, which is a $25,000 one. And then the $100,000 one is the one that's typically used in most other nations except for Canada, which is the $50,000 one. And you'll see that there is almost no study that wasn't cost-effective by $100,000 criteria, $100,000 per quality adjusted life year. That is a sort of a unit-free measure of how well you're doing, so that you could, for example, compare depression against diabetes or depression against a heart disease intervention. And so, in fact, you're doing as good as the best interventions in medicine there. And even if you knock it down to the $50,000 criteria, the vast majority of the studies are also cost-effective. And the majority are even cost-effective in England. So you should walk away from this saying there is almost no chance that if you do this and do this right, that it won't be cost-effective. That it won't be both good clinically and efficient. And so, but let me give you a caution before you get too excited. The caution is that very often when an economist stands up here and say cost effectiveness, people say, it'll save us money. That is not what I'm saying. I'm saying that what you buy, you're going to get a valuable thing at a good price. That's a good deal. Not that it's a negative price, right? Saving money. How many of you have bought something recently that saved you money that you really believed? Okay? We've all heard the story, the shirt was on sale, I saved $100. If I bought them, enough of them, I'd double my income, right? Okay, so that's not right. So what doesn't happen is there isn't any real significant cost offset, broadly speaking, except in a few cases, and that's why I used the diabetes example earlier, because that is one of the places where you can actually save. But overall, it doesn't, unless it's really targeted. The other thing that's important to note is that there is evidence that these models improve work outcomes. And they don't improve work outcomes as much as they improve clinical outcomes, but they do significantly affect work outcomes. Whoops. Okay. So why isn't everybody doing collaborative care all the time, everywhere? Well, one is there's frictions in the way medical practices are organized. You need a little bit of infrastructure. You need a case manager. Ideally, you need a little bit of IT support. And it's usually better if you're hooked in with specialty backup and things like that. And still, in this country, about 30% of practices are still like what I grew up with. Somebody who has a garage in the back of their house that's been converted into a medical practice, and they have an assistant and a doctor. And there's still about 30% of medical practice in this country like that. And then there's a bunch more that are actually small ones and twosy groups. And so it's just harder to implement those things in there. Payment policies get in the way still. In Medicare, you still can't bill for a care manager and a physician visit in the same day. That just gets in the way. We don't use decision supports routinely. I can't tell you how often I've gone into a doctor's office and the major use of the computer is for them to play solitaire when they have some downtime. And in fact, they don't actually use it as a tool of their clinical practice. And then finally, I think there's an attitudinal thing that when you've been practicing in a certain, all of us get into habits. And I probably do economics in a way that's much more similar to the way I was trained than the way the next generation is trained. And doctors are the same way. But delivery system reform can help because it is pushing people into larger aggregates. It's forcing infrastructure around networks of doctors. And it starts to get at some of the things that stand in the way. Okay, let me now turn to the other part of the story, which is the lessons from bringing medical care to specialty behavioral health care. And I'm going to focus on sort of patterns of utilization, what we've learned about that, what things best promote integration, and I promise you one surprise, and some observations from some interviews and qualitative work we've done. You're going to have a hard time seeing this. Can you see that okay? Oh, you can, okay. I can't. But I think I remember the numbers well enough. So we have 3 services here that were part of the demonstration. And what you see is that screening and assessments go way up. They're pretty high. 86% of consumers get screened and get assessed for behavioral health, for medical treatments and behavioral health together. That's very good. On the other hand, you start to drop off quickly when you start to get to the harder things to do. So if you look at treatment planning, which isn't that much harder, but it's a bit harder, it drops down to 72%. And then when you actually go to medication management, that is managing the diabetes medicines on one side and measuring the antidepressants on the other side, you're down around 64, 65%. And so it starts to drop off pretty quickly with the difficulty, but still, these aren't too bad. This next one is just to show you that we analyzed data, and we looked at two levels of integration, where the first level was what we call basic integration, and that just means you screen and you assess people, you plan treatments, and you have regular contact with the other professional. So if you're a behavioral health person, you have more contact with the primary care doctors. And what you see is that there were we found a variety of things, and I'm just going to summarize them for you on this thing. That the lessons we learned is that partnerships between agencies are incredibly important. Like when you have formalized arrangements, you're much more likely to actually pull off the actual integration. That even all the goodwill and all the sort of personal relationships you think matter don't matter as much as when you have those plus a written agreement. It turns out that extra step really matters. Second of all is making sure that there's regular communication along a variety of fronts, including written, oral, and face-to-face. And when you have all of those things going on, there's just way more chance that at the patient level, all the pieces are going to come together, right? So it's just, do the medical and behavioral health professionals interact in a consistent way, and do they do it in a sort of balanced way that it's not just telephone calls, it's they communicate and they touch in a variety of ways. Flexible hours for primary care services is critically important. And the really big surprise is co-location appears to matter way less than at least I thought going in. It matters a little bit, but relatively little. And I was surprised, and it was partly because I had spent a lot of time with people like Frank, who had persuaded me over the years that co-location was critically important. So I walked into this evaluation thinking, boy, that's what we're going to find. And it turns out, you find a little bit of it, but all these other things are way more important. So you can accomplish integration by doing a lot of things that don't involve co-location and still get the benefits. So the common elements of successful models are care planning across providers, use of the evidence-supported models, defining clear roles for treatment team members. The primary care doctor, the care manager, the behavioral health specialists shouldn't be trying to do each other's work. They should stay in their own lanes and talk to each other. That seems to be the answer. It's that when other people try to do what they're not really that great at, it doesn't work that well. And then you need to build systems so that you get the right information to the right parties at the point of care. And this is not, on one hand you could view this of, oh my God, I need to spend $10 million on an Epic system, but actually probably a good spreadsheet can get you most of the way there. And then finally, you need to consistently measure and track outcomes. Greg Simon talks about measured care or something like that. And I think that that's really, it turns out the evidence sort of bears him out. So let me sort of start to wrap it up here. I think the two sides of the integration question, I think, are equally important. We're way ahead of it in terms of evidence, in terms of knowing exactly what to do on the side of bringing behavioral health to primary care than we are knowing the exact model that's most likely to work on the especially the behavioral health side, but we're getting there. We have promising models, we have some learning that's going on, but we're half a generation behind the other literature. Second is the Affordable Care Act offers new resources, new incentives, and new institutional forms that if we do them right and we stay on top of them, can really promote the idea of integration. President Clinton once said, for most problems in the world, somebody somewhere has figured out a solution. The real challenge is finding out the one that really works and scaling it up. And so I think really the big challenge today is figuring out quickly where the best bets are on the specialty side and starting to really scale those up. and to continue to get things out of the way of scaling up what we've learned so well on the primary care side. And my favorite candidates here are aligned payment arrangements that don't get in the way, modest infrastructure investments, particularly around information technology, and then commitment to execution at the ground level. And this is not something you typically hear an academic saying. I would have never said it 3, 4, 5, 6 months ago. But the execution is so critically important, and the accountability that goes with it. So the learning to date, I think, suggests that we can measure the things that promote this stuff. And if we can do that, we can embed within our accountability systems that govern accountable care organizations, health homes, and the like, those measures, so that we don't go off the rails, so that the high-powered incentives give us flexibility to do the right thing, but don't give us so much flexibility that we can do the wrong thing, because we can measure and keep people's feet to the fire. And again, measurement of performance and accountability at the end of the day is critical, and that's accountability both at the enterprise level, but also accountability at the systems level, where we have regulations and payment arrangements where we hold people accountable for the way they use our money. So I'll stop there. Thank you.